Buen día. Bienvenidos a la serie de conferencias de Líderes Internacionales, una iniciativa de nuestro Laboratorio de Salud Mental y Bienestar, para conectar expertos internacionales con la comunidad mexicana. Esta iniciativa nace debido a la gran brecha que existe entre el conocimiento basado en ciencia y el acceso a este. Para ello, hemos diseñado una serie de conferencias en línea gratuitas que serán impartidas por expertos internacionales, con el fin de que puedan ser de utilidad tanto para profesores y estudiantes como para la comunidad en general, incluyendo profesionistas de diferentes áreas y padres de familia, con la facilidad de tener acceso desde cualquier ubicación. Esta iniciativa también tiene como objetivo el desarrollo de nuevos proyectos de investigación y de la ampliación y consolidación de redes de colaboración académica internacional. Con el fin de unir esfuerzos y llegar a un mayor número de personas, estaremos colaborando en cada conferencia con una institución mexicana. En esta ocasión, nuestra colaboración es con la Universidad Autónoma de Yucatán. Permítanme presentarme. Soy la doctora Julia Gallegos, profesora investigadora de la Escuela de Psicología de la UDEM y directora del Laboratorio de Salud Mental y Bienestar. Nuestro laboratorio tiene como objetivo el realizar proyectos de investigación en las temáticas de prevención e intervención temprana para la ansiedad infantil, adaptación cultural y validación de intervenciones e instrumentos, resiliencia y competencias socioemocionales y psicología positiva.
Gracias, Julia. Muchas gracias. Permítame también presentarme. Soy el doctor Elías Alfonso Góngora Coronado, profesor de la Facultad de Psicología de la Universidad Autónoma de Yucatán. En primer lugar, quisiera agradecer a la doctora Julia Gallegos la invitación para que la Universidad Autónoma de Yucatán participara en esta iniciativa tan interesante a la que he hecho referencia a través de videoconferencias. En segundo lugar, agradecemos a todas las personas e instancias que han colaborado a la difusión de este evento y a quienes se han conectado ahora para participar. Y en tercer lugar, desde luego, agradecemos todos a la doctora Ehrenreich-May por compartir generosamente su tiempo, experiencia y conocimientos. Ahora, si pasamos a la siguiente diapositiva, ahí podremos ver algunas ligas principales de lo que es el Centro de la Felicidad del Laboratorio de la Salud Mental y Bienestar. Creo que hay una diapositiva adicional, y de la doctora Ehrenreich-May de la Universidad de Miami. Pasamos a la siguiente diapositiva, por favor. Ahora voy a explicarles algunos aspectos técnicos muy brevemente. En la parte de la izquierda podremos ver que aparecen subtítulos. Para activar los subtítulos, en el punto número 1 aparece la ventanita esta y se le da clic. En el segundo lugar se selecciona ya sea Show Subtitles o Mostrar Subtítulos, en donde está también la imagen. Y en el punto número 3, una vez que se ha hecho esto, se activan ya los subtítulos. En la siguiente diapositiva, por favor, aparece también lo relativo a las preguntas. Entonces, ahí en el punto número 1 se selecciona esta imagen que está ahí y después aparece ya en pantalla donde se pueden realizar las preguntas. Muy bien, entonces, ahora, sin mayor preámbulo, permítame presentar, por favor, algunos detalles de la trayectoria de nuestra ponente de hoy, a quien agradecemos de nuevo estar con nosotros esta mañana, para compartir su experiencia acerca del tema que se ha titulado Protocolos unificados para el tratamiento transdiagnóstico de los trastornos emocionales en niños y adolescentes. La doctora Jill Ehrenreich-May es profesora de Psicología, Psiquiatría y Ciencias de la Conducta en la Universidad de Miami. Recibió su doctorado de la Universidad de Mississippi en el 2002. Es autora de más de 120 trabajos publicados, incluidos manuales de tratamiento, artículos y libros. Las investigaciones recientes de la doctora Ehrenreich-May incluyen temas relacionados con la efectividad de tratamientos en el estrés emocional de los jóvenes en ambientes comunitarios y tiene particular interés en las intervenciones transdiagnósticas para los jóvenes con trastornos emocionales. Muchas gracias de nuevo a la doctora Jill. Y vamos a iniciar y le concedemos, por favor, la palabra. Tiene usted la palabra, doctora Jill. Muchas gracias de nuevo. Adelante.
Hola, mi español no es tan bueno para una persona que vive en Miami. So I'm going to switch to English and do this webinar in English today. And I'm going to start by slides. One moment. Well, thank you so much for having me, and I'm truly honored to be presenting to you today about some work that that has really been the main focus of my career, which has been in developing transdiagnostic treatments for youth with emotional disorders and really thinking about them as one avenue to try to bring evidence-based treatment strategies to more children and adolescents. Before we begin, I just wanted to make a few financial disclosures. I am the developer of the treatment guide and workbooks for the Unified Protocols for Children and Adolescents, which we'll be speaking about today. And I do make a small royalty from these. I also receive financial reimbursement for clinical trainings and consultation, as well as implementation support. And we have been very lucky to have a fair amount of research funding to support our work as well. Today, I'm going to briefly I'm going to briefly touch upon youth emotional disorders, what they are, and the cost associated with experiencing them. I'm going to talk about some barriers to implementation of evidence-based therapies and really talk very specifically about how transdiagnostic treatments might be one avenue for overcoming certain barriers to the implementation of these therapies. I'll describe our unified protocols and then briefly speak about research that is ongoing, of course, on our versions of this treatment for children and adolescents. So you're probably quite aware already, if you are on this webinar, that youth emotional disorders are a really huge problem that are experienced by so many of the children and adolescents that we work with. In fact, they are the most prevalent mental health disorders that are experienced by youth. We know that they start early in the development, oftentimes by middle childhood, experiencing those things at a clinical level, and that they can be quite impairing, meaning that they get in the way of normal development at home, at school, and in one's community. What we will talk about in just a moment is that we can effectively treat these conditions, which is the good news. The bad news is that we are not treating these things effectively often enough, and when we don't, that they are going to often persist into adulthood and be associated with a number of negative outcomes, such as suicidal ideation or substance use. Oh, for some reason that's not working. Okay, there we go. Once again, the World Health Organization has put together data that suggests that at least 10% of the world's population are affected by these conditions. And importantly, there are multiple indicators that these symptoms are increasing in frequency, not decreasing in frequency. And the cost experienced because of medical costs, because of lost revenue from work and school, is quite high related to these disorders, maybe as much as $1 trillion of US dollars annually. So for every one of those US dollars, however, that we might invest in intervention, there seems to be the suggestion that we can get better return on that investment relative to improved health and occupational outcomes that are costing us globally so much money. And so it seems kind of a no-brainer. Like, of course, we need brief evidence-based strategies to help address these anxiety and depression symptoms. That seems like an obvious solution. And in fact, we have really wonderful treatments with good efficacy data for these types of conditions. For example, I've provided you with a small graph here related to the child and adolescent anxiety multimodal study that was done in the United States across multiple sites and funded by our National Institute of Mental Health. And what this showed was basically that cognitive behavioral therapy for anxiety disorders in youth over a relatively brief period of time of about 12 sessions, resulted in about 60% of youth experiencing some level of clinical remission following that brief treatment. It was just around similar, maybe just a little bit better than a selective serotonin reuptake inhibitor. And importantly, as many as 80% of youth achieved remission when these SSRIs and CBT were combined together. So that seems really good. We've seen these effects across multiple sites, in multiple settings, with these kinds of strong effect sizes, perhaps a little bit less for adolescent depression or for pediatric OCD, but the cognitive and behavioral interventions for those conditions are also pretty good. And we have some suggestion that either parent-directed or youth-directed CBT can help with anger or irritability in youth as well. So you may be asking yourself, all right, well, this all just seems good. Talk over. You know, why don't we just apply these existent CBT packages for these specific concerns to youth? But when we kind of dig into the data a little bit more, we can say that there are some avenues for improvement. One of them is the longer term retention of good gains that are made immediately in these kinds of treatments. So for example, in that child and adolescent anxiety multimodal study, we found that, for example, 6 years later, about 50% of the kids had actually gone back to having a clinical concern when they were followed up with. So in other words, the effects weren't as lasting as we might hope they would be. And that makes us think about what were we not treating or what was missed in that brief intervention importantly. We can also think about the fact that these things have been tested largely in very highly controlled circumstances with clients who predominantly present with one problem or another, not the multi-problem youth that we think may be more representative of children that we work with on a daily basis. Let me switch gears for a second and talk about some barriers to using these really great treatments that I've already been talking about. You know, you're participating in this possibly in part because you've already gotten some good training in evidence-based therapy, or you're very interested in it. But that's not always the case in many training programs, at least here in the United States. They're often quite variable or little to no training in some degree programs. And once people finish their master's degree or they finish the program of study that they're in, there's often very little time post-degree to get additional training or supervision or support in a new evidence-based therapy. For people who are working even within an agency that does support this, there might be some logistical or financial barriers. These things can be quite costly in terms of time or money. I've noticed in some of our effectiveness research on the unified protocols as well that it can be quite stressful for practitioners to adopt some new evidence-based therapy models as well. So if you've been trained, for example, predominantly in family therapy, you might find that it is quite stressful to suddenly start being expected to do CBT. One important barrier that I haven't talked about, though, so far to the uptake of evidence-based therapies is related to the good effects that I showed you a moment ago, which is that we have really done a great job of creating many specific protocols for the intervention of emotional disorders in children and adolescents. I'm showing you a couple of these right now, but there are so many more that are focused on a specific problem or a specific domain or even a specific technique that we work with. And I think what is going to be really important for us to discuss now is that this is not necessarily how most children present. So for example, a child that presents with, panic, or a child that presents with sleep problems or depression or OCD likely has other concerns as well that may not be addressed within one of these single domain or disorder focused treatments. And importantly, as a practitioner and being a practitioner myself, I know that it's not really how you go about doing treatment most of the time. Oftentimes we deliver interventions in a much more flexible or even eclectic manner. So just to dig into those two issues a little bit more. As mentioned just a moment ago, we think that some of these sort of single domain or disorder protocols might lack flexibility in their target or their delivery models, whereas we know that multi-problem youth are really the norm. As many as 75% of children are going to have at least another concurrent emotional disorder diagnosis. And of course, we know as child-focused practitioners that many of these disorders are not going to just occur at the same time, but that a child with, say, separation anxiety is going to come back later, a couple of years later, with generalized anxiety or OCD, and come back a few years later than that with depressions. We also have to think about prevention in our treatment choices. And this is true whether we're thinking about co-occurrence within disorder categories like multiple anxiety disorders, or thinking about changes in the problem over time between types of problems. And this could make that decision about which of these really great protocols do I actually use. We could say that to a certain extent, some of this issue with co-occurrence and multiple problems is a problem of our categorical system. So things like the DSM or the Diagnostic and Statistical Manual of Mental Disorders, or the ICD, share problems with the difficulties presented or the domains presented not being completely independent of one another, leading to a lot of sort of shared criteria between disorders. So for example, something like rumination, or, kind of thinking about a problem over and over again, can be a problem that is shared by things that are more depressogenic or things that are more anxiety based. But we could also say that some of the rationale for that co-occurrence is also relative to the shared genetic, neurobiological, and environmental factors that occur across these conditions as well. In fact, there are so many of these that individuals like David Barlow and others have proposed the idea that there is a higher order factor or something like a negative affective syndrome that might be descriptive of individuals with these kinds of conditions and explain some of this change over time between different related conditions within the internalizing domain. Other people have spoke about things like rumination or intolerance of uncertainty or anxiety sensitivity as being other potential shared factors between some of these concerns. So going back to our treatments for a minute, what this might suggest is if our real world patients are actually individuals who present with a great deal more comorbidity, either concurrently or over time, that it's possible that our treatments would be of more limited benefit if they were too specific. And in fact, some researchers have found that, such as John Weiss and Bruce Torpeda. John Weiss also wrote a paper with Marchette that suggested that, we have to think about problems also shifting or changing during even a course of treatment between some of these problem areas. And so really we need to concentrate on increasing the flexibility in the way we deliver our evidence-based interventions, which shouldn't actually be that big of a problem because honestly, we are, we have many, many, many shared components across these really great individual protocols for these different emotional disorders. If you were to dig into any one of these great manuals, you will probably find a lot of the same things, like a focus on identifying emotions and labeling that process effectively. Really teaching children and their parents about how one's emotion state will impact certain behaviors, leading to things like avoidance or aggression or compulsion. They contain intervention strategies that can usually be lumped, at least within CBT, as more cognitive. So things like cognitive restructuring or mindfulness, or might be lumped as more behavioral or opposite action strategies. So things like increasing activity, problem solving, or a litany of exposure strategies. Now, what these protocols do vary on a little bit more is to what degree the caregiver is involved. But when the caregiver is involved, there is typically at the very least an education focus to that involvement. So giving the parent the same information that you're teaching the child. But in some cases, there are also strategies that are more explicitly trying to adjust parenting behaviors that might in fact impact a child's emotional disorder. So for example, like overly accommodating a child's anxiety. So I'm going to switch gears now and talk a little bit about one way in which we're going to address, or we could address, some of those barriers using a transdiagnostic intervention approach. As may already be evident, I'm thinking there may be some advantages to this type of treatment. Some of the advantages we could consider as we discuss are things like potential increased efficiency if we have a multi-diagnostic or a transdiagnostic evidence-based package. We might reduce training costs to organizations if we don't have to train them in multiple manuals that largely accomplish many of the same goals. And as mentioned, this might be better fit. We don't know for sure, but it might be a better fit with how practitioners actually use evidence-based strategies, or a better fit to the client characteristics that they're seeing in front of them. And we would hope that that would lead to greater satisfaction with treatment. So I want to be quite upfront that I am certainly not the only person working on the idea of transdiagnostic treatment. There are many approaches that are similar to what we are doing. They have been labeled differently, but they largely are the same in many ways. So John Weiss and Bruce Torpeda developed something called the MATCH protocol that you could think of as a common elements approach to transdiagnostic treatment. The real difference here is that there are sort of distinct silos of techniques for, say, anxiety, depression, trauma, conduct problems, and you would use an algorithm to know when to switch between these different silos of strategies, if you will. John Weiss has also developed a related protocol called the FIRST protocol, which is more of a principle-guided approach. This is really, in some ways, to try to harness some of the good elements in something like a match using a more flexible structure that allows the clinician to kind of move a little bit more easily between different foci within treatment. And most people have characterized what we do in the unified protocol as a core dysfunction-oriented approach, meaning that you're using these, largely same evidence-based strategies in a more singular or consistent way, because we believe that we are impacting a higher order factor that cuts across related classes of disorder. So we're really concentrating mostly on the emotional disorder sphere with the unified protocols for that reason. So this is what the manuals and workbooks look like. And I want to highlight a couple of elements that make them a bit more flexible. The adolescent protocol, which was the first that we developed, has a modular structure and features common or core treatment principles that can be flexibly applied. The way that we get away with that is by doing so across a range of emotional examples. So we give examples in the manual related to fear, anxiety, sadness, or anger / irritability, but they can be applied to a much broader range of emotional targets or emotional behavior targets as well. The child-focused version of the protocol, as I'll show you in a moment, is written in a more fixed structure, but it is often applied in a more flexible manner as well. So before I get into the nuts and bolts of the treatment, I did mention this idea of a core dysfunction. And I've hinted at this already in our presentation today, but we think that what we may be targeting is something that we could call something like neuroticism. And certainly neuroticism is not a new term within psychology or within the psychotherapy literature, and harkens back well before the advent of cognitive and behavioral treatments. But we're going to kind of define neuroticism here and what we're targeting with the UP a little bit more specifically. Yes, neuroticism may be a trait-like tendency to experience strong negative emotion. And in fact, these are kids who feel their feelings, more strongly, more intensely, perhaps more negatively than other kids. But importantly, they are experiencing that process with a lot of distress. So they find it really intolerable to have a strong emotion, and in fact are going to, attempt to try to get rid of that experience, either cognitively or behaviorally, and we could call that experiential avoidance, as quickly as possible, leading to further problems. I'll expand upon that more in a moment. The Unified Protocols target all anxiety disorders. We are in the midst of publishing a paper right now that nicely supports the efficacy of the UPs as well for OCD, and that's something that has also been established in the adult literature. We think that you can use these techniques more briefly for somebody who might have adjustment concerns. With depression, we've seen a slightly longer course of intervention, oftentimes for kids with depression, but think that the problem itself remits nicely. And interestingly, the Unified Protocols have been utilized with really an array of other problem areas as well. So there is literature about their use with things like PTSD. We've been working with a child maladjustment group that has been, that has worked with children who have been maltreated. We are working with another group that has worked on the use of these techniques for eating disorders, particularly for avoidant and restricted food intake disorder, or ARFID as it's called in the US. We've looked at, and the adult groups have looked at borderline features, bipolar disorders. I'll speak a little bit more about our work with anger and irritability, and others with serious mental illness. Now, importantly, I think of when I talk about that long list of other things the UP has been applied for, I want you to be clear that I don't necessarily think that it always remits all of the symptoms of these other non-emotional disorders. I think what it does is in fact remit a lot of co-occurrence related to anxiety and depression, and perhaps with the case of anger and irritability, perhaps reduces irritability more directly. And the reason is that even across other co-occurring conditions, that we think that these emotional disorders are going to be maintained by similar processes. So when I was talking about the neuroticism model a moment ago, that relates really strongly to our case conceptualization model for the UP. And we generally think that any child is appropriate for the UP if they are in fact experiencing a frequent and intense experience of their strong emotions, that distress reaction. Now, they may not tell you, I think this is bad, I want it to stop, but you'll see it in the child's behavior, and specifically kinds of behaviors to control, avoid, or suppress their intense emotional experiences. And that could be aggression, that could be withdrawal, that doesn't necessarily have to be just avoidance. So what happens when we avoid or we engage in another emotional behavior to try to get rid of that distress reaction? Well, it makes it go away, at least temporarily. So for that brief amount of time, you feel better when you engage in one of these behaviors. And it sets up a system whereby that behavior is reinforced over time. And eventually the child may really feel like they don't know what else they can do. They may have poor self-efficacy to deal with their emotions in any kind of different way. The UPA, as mentioned, is a modular approach. It does not have a set number of sessions. We do view it as relatively time limited and appropriate for children who are about 12 and over. Just to walk you through the strategies briefly, we start the intervention typically with some level of motivation building. The modules can be flexible in the ordering in which you provide them, but most people will do motivational enhancement at least one session first. And within that, we frequently set something we call top problems or top challenges so that we have a personalized tool to kind of understand what are the major concerns for that child and then assess them week to week to also understand when the intervention is perhaps working its best and when it may suggest that the child does not in fact need additional intervention anymore. Typically we also provide the psychoeducation module or module 2 next, getting to know your emotions and your strong behaviors. We go over that case conceptualization model directly with kids so that they really understand why they are engaging in some of these emotional behaviors. And that is an incredibly helpful thing. We also really focus in on increasing awareness and affective labeling within this module. The rest of the modules can really freely vary in their order. So for example, just a few moments before I did this webinar, I was doing supervision and we were talking about in module 3, we typically introduce behavioral activation and, you know, as an opposite action and a type of experiment that the child can engage in order to start seeing that other things can be true when we experience a strong emotion other than just the primary behavior that we've normally been engaging in when we feel sad or we feel irritable, for example. But in this case, in supervision, we were saying, well, you know what, this child predominantly has generalized anxiety, and we think it would be more helpful to introduce mindfulness first. So we're jumping ahead to module 6, awareness of emotional experiences in that case, to introduce present moment and non-judgmental awareness. Module 4 includes more of that non-judgmental awareness, but particularly as it relates to body sensations. We also have interoceptive exposure techniques within Module 4 in order to allow somebody who might have more panic-like symptoms or a high anxiety sensitivity to engage in new situations, even when they feel those strong feelings in their body. Module 5 has a number of cognitive techniques, including problem solving and reappraisal. And of course, the major focus of a lot of the UP is very exposure-based, exposure to emotion, and not engaging in problematic emotional behaviors. So that could really cut across a very wide array of exposure targets, and that may make up a good proportion of your treatment with them. And we do have a pretty significant caregiver module that I'll talk about more in a second. Our child manual is really fun. We've written it as a 15-session group. I think if you've never used the UP, it's really great to do the group first because I think it's just a great learning experience. You get to go through all of the techniques and you get to go through all the caregiver material, and I think people feel a lot more confident in delivering the intervention after they do that. But of course, it can be delivered as a modular individual therapy. UPC, we used to call it emotion detectives. In fact, some of the early publications reference it as emotion detectives, and that's a metaphor that we use within the treatment to try to let kids know that they're going to learn to become a detective and look for clues to solve the mystery of their strong emotions. They also learn the clues skills: consider how I feel, look at my thoughts, use detective thinking and problem solving, experience my emotions, and stay healthy and happy. And you can see the content is just completely parallel to what's in the UPA. The only difference is if you're providing it in a group, you would be doing so in a more fixed order. Just to point out, there's a lot of similarity between the 3 versions of the manual that have been published for young children, for adolescents, and for adults. The adolescent and adult versions are written as purposely modular. The only other really important thing to know is that all of the caregiver material is in the UPC workbook or the child workbook. So what caregiver behaviors are we in fact working on in the UPC? Well, the way I frame it, or the way we frame it in the intervention, is really to think about it as caregivers, whether that's parents, teachers, other people in the community who are working with this child, often will fall into some patterns of behavior, really, oftentimes out of good intentions, that end up reinforcing a intense experience of strong emotions or some unhelpful coping behaviors. And we refer to these as emotional caregiving or parenting behaviors in both the UPA and UPC. The ones that we've labeled sort of the strategies under are excessive criticism, and of course, no caregiver or parent really ever goes into an interaction with a child intending to be negative, intending to be critical. But what can happen sometimes, even as somebody is just meaning to be helpful, is that they end up focusing a lot of their verbal and physical attention to behaviors that they actually want to see less of rather than more of over time. There's been a lot of literature on caregivers and others who work with youth who have particularly anxiety, accommodating or over controlling situations in order to lessen the experience the child is having of distress or to help them avoid situations that are hard for them. And we know that this turns out to be unhelpful for youth over the longer period of time, although it's complicated when you are actually in a situation with somebody who is upset, because we have learned as parents from the time our child is very young to address their worry and their upset as directly as possible, because that is part of being a good parent. So it's very hard to get out of that habit when it's not actually as useful. We have some parents with psychopathology or difficulties themselves who need to learn other words to express when they're feeling some level of distress or when they feel the urge to avoid. And I'm not going to get into it in as much detail, but there are also a number of behavioral parent training strategies to help families with more inconsistent reinforcement and discipline patterns as well. So you can focus on these flexibly within the UPA. Within the UPC, they are given as sort of different parent group content areas and sort of spaced out throughout the intervention. So this is just the order in which we discuss these different caregiver issues. We also spend a lot of time just with parents in learning how to identify what emotional caregiving behaviors they might be engaging in right now. I think across all of these techniques, a lot of the emphasis is on paying more attention to the behavior you want to see more of and less attention to the behavior that you want to see less of. I think that's the fundamental strategy that cuts across all of these types of techniques. And importantly, I try to emphasize that, you know, these are just extremely common behaviors. Every parent does them. Everybody who's working with a distressed child is going to engage in them. And they really all come out of well-intentioned efforts to reduce a child's distress. But we think everybody can really benefit from learning more about them. And, you know, as I work with new clinicians who maybe have not experienced parenting themselves, you know, a big thing that we talk about is empathy, you know, that caregivers are allowed to have their feelings too. And we definitely don't expect caregivers to deliver these things perfectly. So interestingly, in recent months and years, we've been working on thinking about some of these caregiver-directed UPC strategies as a standalone caregiver curriculum and have a grant under review right now to consider doing that. There's also a number of studies outside the United States that are interested in looking at, say, the caregiver-only component versus a child-only directed UPC. So I think we'll have more information about how it works in that manner coming up in the next couple of years. So just to review the evidence base for the existent protocols, the UPA was really the first intervention that I developed from an existent collaboration that I had with Dr. David Barlow at the Center for Anxiety and Related Disorders at Boston University. And as part of a treatment development trial, we conducted several early trials to, in fact, develop and differentiate the UPA specifically for adolescents and develop its caregiver components as well. And all of those were generally supportive of the intervention and showed a fairly large effect size when we did the randomized controlled trial versus a waitlist condition. However, some of those studies are limited. They were predominantly for kids who had more anxiety than depression. That's been a problem in a lot of our trials. There weren't as many kids with OCD. And, you know, we weren't initially comparing it to another intervention as well. So we have remedied a lot of those concerns. There are 2 funded trials looking at the effectiveness of the UPA in community settings. There are several more services-oriented grants that are also currently funded and underway in differing community settings that I think will let us know a lot more about the acceptability and the satisfaction and the effect of these protocols when delivered by community clinicians in community settings and not just in a much more protective research environment. Some of our colleagues in Spain have published a series of studies about using the UPA in a couple of additional formats. One is a universal prevention, where they found good effects for the UPA, but generally speaking as a selective prevention, which what all that really means is that it really worked best for kids who already had some heightened anxiety or depression concerns as opposed to kids who didn't have those. And again, that's not too surprising to me because I think anything with an exposure component is generally going to work better for kids who already have some of those concerns. They've also developed an internet-based application of the UPA in Spanish, and just published a protocol paper, I think just days ago, on that study as well. And I know they're going to be presenting some of that work at a conference here in the US in November. So as far as the UPC, we did this as a downward extension of the UPA here in Miami. Myself and my colleague Emily Bialik, who's a professor at the University of Michigan now, did a number of studies initially as a prevention, as an open trial, and then along with Sarah Kennedy, who's a professor at the University of Colorado School of Medicine now, did a randomized controlled trial comparing the UPC to cool kids. And what we found in that comparison to a CBT protocol that more targeted anxiety disorders alone was that, not surprisingly, these treatments were largely equivalent in their effects. That has been the same as we have found with comparisons between the adult UP and several disorder-specific CBT protocols, that they are at least as good, in other words, as these more disorder or domain-specific approaches in terms of at least within nice, clean efficacy trial settings. But we did find some intriguing things that led us along the path of thinking we need to know a little bit more about the preventative effects or other effects of delivering the UPC. So for example, there were some suggestions in that early trial that the UPC was a little bit more robust in preventing symptom recurrence at our 6-month follow-up. Kids were doing very well at the 6-month follow-up in that UPC group in terms of co-occurring depression symptoms. And I think, interestingly, there was a strong effect indicating that cognitive reappraisal was in fact greater in the UPC group than the cool kids group, which was a surprise to us initially, but I think may reflect the fact that we teach both mindfulness and restructuring and problem solving at various points during the UPC. So there's a lot of opportunities to get more flexible thinking happening. So we've been really interested in personalization, like how do we sort of make decisions about how much of the intervention to give and also how do we know when treatment response is happening? And we've been focusing some of our recent trials on that as well. We are, of course, also really interested in mechanisms. We have hypothesized that changes in distress relative to the experience of a strong emotion is one very potent possible mechanism of change within this intervention. We recently just published, I think it's online now, a paper that Jamie Sherman is the first author of, looking at using some sophisticated modeling techniques of a non-concurrent multiple baseline design study with 9 adolescents who had both anxiety and depression to look at patterns of change in that kind of distress regulation, but also in avoidance and cognitive flexibility. And what we found was that those things did change at expected time points in the intervention when we were delivering material related to those types of mechanisms, but also seemed to be associated with symptom change. So it was a little bit hard to sort of separate whether these were mechanisms or whether these in fact were outputs of the intervention. That's something that we continue to look at now in a much larger multi-site effectiveness trial. So we have finished recruitment for what we call our Comet Trial, which was a study, in fact, one of the largest studies of a transdiagnostic intervention or multi-diagnostic intervention in effectiveness settings to be implemented. We had adolescents and therapists across 16 community mental health centers in the United States, in both Florida as well as in the northeastern part of the United States, randomized to a treatment as usual condition, a treatment as usual condition plus a measurement and feedback condition, where they got sort of a weekly measure to let the clinician know how they were doing and some support for progress monitoring, and then using that information in session, and then the combination of that with the unified protocol. We have recruited all of our participants. We're just doing the follow-ups now, so I'm hoping that we'll have data to share within the next few months, probably at least, in the beginning of 2021. These were much more difficult cases than we have ever faced in any of our efficacy trials. These were children who were very low income, who had multiple life stressors, The context in which they receive services varied quite a lot. Some received services in their home, but many received it at school, or in some received it in the office, many received it at home or in school. It was almost all master's and bachelor's level clinicians. But we are very interested in the process of change, even if it turns out these interventions don't turn out to be that different in terms of their effects, given all the difficulties of just literally delivering the interventions. But, you know, I think we will understand more about the mechanistic process by which change will have occurred differentially between these conditions. I think the other thing we really learned, honestly, with this study was just how difficult it is for many of our master's level clinicians to deliver services in some of our community settings. We had such rapid turnover of clinicians that we were really literally constantly retraining people in the study. We had almost as many therapists as adolescents in the trial, which is kind of amazing to think about. So to wrap up, you know, some of the things that we're thinking about as we move forward with some of our research efforts, we are very interested in applying the UP in a lot of different contexts and with different conditions, as mentioned. We have studies that are ongoing in service sectors and in sort of more controlled settings as well, in providing it in the unified protocol in a stepped fashion, via telehealth, and in schools. We're also really interested in the application of these common transdiagnostic processes or evidence-based strategies to other related emotional disorders. So we have a study, for example, ongoing here at the University of Miami, as well as at the University of South Florida, to adapt and apply the UP for misophonia, which is having a very strong distress or aversive reaction to certain types of noises. So there is a translation, an official translation of the materials to Spanish. I say official because many people have made their own materials out of it while we've been waiting for the official version of the manual to be published. I've seen the UPA workbook and I've seen parts of the UPC workbook, so I know it is coming. It's supposed to be published sometime late in 2021. There is also a book available. I've provided the link, of adaptations of the UP, in which we have 2 chapters in Spanish about adaptation of use of the UPC as well as use of the UPA, and that's the link to that book, and the editor is Jorge Asma. And finally, just as an example of, you know, something new and exciting for us, I think we're really excited about the use of these materials for irritability or disruptive behavior, which is a group that we've seen all throughout our attempts to provide this intervention to individuals with anxiety and depression, but felt like we needed to make some structural changes to the intervention in order to deliver. So my, again, former student, Sarah Kennedy, along with Jessica Malmberg, now Hawks, at the University of Colorado, adapted the UPC, although it retains most of the same child-directed curriculum, a lot of changes to the caregiver curriculum to really focus in more on that inconsistent reinforcement and discipline end of things. And knowing that kids who are irritable and have ADHD or disruptive mood dysregulation disorder or other related conditions, as these kids did in this trial, cannot probably sit through 15 sessions. They shortened the intervention to 10 sessions, enhanced the examples related to anger and aggression and frustration, and I think really in a cool way, really enhanced the exposure element of the treatment. So starting in session 3, what they do is a parent-child exposure element within session to engage in sort of a frustration trigger or sit with a frustration trigger. So things like, it can be anything from playing a loud noise to asking the child to do a task they don't like folding laundry, or to, you know, write an apology note to their sibling, something fun like that. And we scaffold up the parents' involvement and decrease the therapist's involvement in these exposures. So we've piloted a pilot study. It is online. It's actually Hawks et al. In behavior therapy with 19 children. It showed a nice decrease in irritability and disruptive behaviors using this approach. And we're very excited to continue to follow up this work as well and have some plans to do so in the next year. I do want to make one last point that these treatment materials, at least in English, are available for free on the Oxford Clinical Psychology website. That website is very difficult to navigate, so I apologize for the very specific links that are on here. But if you go to these links, what you will see is a list of all of the worksheets and forms within the manuals for each of these 3 iterations of the materials. And you can download them and use them in a fillable PDF format, which is really great. So that's all that I have for our webinar today. I just wanted to say thank you to all of my collaborators, as well as my former mentor, David Barlow. And of course, you know, none of this work is ever done in isolation. I definitely don't do it all personally. So I wanted to acknowledge my students and staff who have worked with me over the last many years, both at Boston University and here at Miami. So with that, I'll turn it back over to Julia to answer any questions.
Jill, thank you so much for this wonderful and interesting conference. We are going to pass to some questions, the section of questions and answers. We have here some questions that we have been taking note of. And please, participants of the webinar, write your questions in the chat. I'll pass the microphone to Gabby. She will say the question in Spanish and then in English, and then Jill will answer in English, and our translator will make that Spanish translation for us. Thank you.
Hi, Jill. Okay, so the first question, I will be reading it in Spanish and then in English, okay? La primera pregunta es, ¿qué implicaciones tiene en la práctica con el tratamiento en grupo en los niños con diferentes trastornos emocionales? ¿Qué modificaciones se harían en este caso? The first question is, what are the implications in the practice of group treatment with children with different emotional disorders? Will there be a modification?
So, you know, many people ask me this same question about, you know, is it really okay to treat kids who have all of these different kinds of problems together at the same time? And I think, honestly, with our young kids, the answer is there has not been a problem. We have really seen a great usage of the strategies transdiagnostically and even across a pretty wide age range. So for example, in our current group right now, there are kids between the ages of 6 and 12 in the group, boys and girls with differing concerns. That being said, you know, we do think a lot about there being something in common between the group members as we're forming them. That could be age, that could be problem type. And it's nice if, for the parents especially, to have some sense of similarity. But I think at the end of the day, the strategies still work really nicely across a lot of different presentations.
Thank you, Jill, for answering the question. I'll be reading the second one. La segunda pregunta es, ¿cuál es el proceso de evaluación para que un niño o un adolescente pueda participar en el protocolo unificado? ¿Cuándo se decide si es mejor para el individuo estar en un formato individual o en un formato grupal? What is the screening process for a child or adolescent to participate in the UPC or UPA? When do you decide if it's better for the individual to be in the group or individual formats?
That's a great question. I think that there are a lot of more simplified assessment tools that you could use because it doesn't require a particular diagnosis of one disorder versus another in order to include someone in treatment. So you could use a brief diagnostic interview, for example, like the CHIPS or the mini kid, for example, and just know that generally speaking, they have some anxiety or depression related concern. We use a more extensive interview because we're in a research setting, as well as questionnaires and some other tasks. But in addition to that, thinking about this group versus individual question, I think is a really good one. We often get a kind of a clinical sense when we review these cases weekly about which they might be better for. You know, is there going to be a real difficulty that especially some of our little ones might have doing an individual therapy process that could be reduced by having them do a group instead? Are there kids who might take a really long time to open up, but in the group can sort of feel like they're in a class or something that they're more used to? Those are often reasons that we will put them in the group instead of individual, or their caregiver really needs the parenting component. I think one thing that has sometimes been different with the individual therapy approach is that, you know, on occasion, when you're doing individual therapy, you just don't have as much time to focus on the caregivers as you might be able to do if you were running a concurrent parent group with a child group. So, you know, for parents who we know really need those strategies, a lot of times we'll put them in the group. You know, I didn't really talk about the adolescent group. We do run a group for adolescents as well. I think that group versus individual decision probably works in reverse. I think a lot more times we recommend the individual versus the group for the adolescents. I think for efficiency's sake, you can certainly run it in a group also. But I think that sometimes the adolescents, you do have to think a little more about how similar are they? Will they get along? Will they support each other? Whereas the kids, the younger kids, tend to be more supportive of one another overall.
Thank you, Jill. I'll be reading the last question, okay? La tercera pregunta es, felicidades, Jill, por el gran trabajo. En términos de las habilidades y los módulos de los padres, ¿cuál sería tu recomendación para comprometer a los padres en la práctica de estas habilidades en diferentes contextos? So the last question, Jill, is, congratulations, Jill, for the great work you're doing. And in terms of the skills of the parent models, what are your suggestions to engage parents and practice the skills in different contexts?
Sure, thank you. Thank you for the kind words. You know, my take on the caregiver intervention has really been about being very sensitive to the fact that parents of youth with emotional disorders are really a very heterogeneous or varied group, some of whom have a lot of difficulties and emotional concerns themselves, some of whom are parents that do not have those kind of concerns and are trying their best to deal with a child who is really sensitive and has a lot of difficulty managing some of these situations and is not sure from, you know, how to handle that. So we really across settings, across situations, try to really lead with a lot of empathy, a lot of consideration of the fact that you will do these emotional parenting behaviors. Every parent will do these things from time to time because it throws you off when you are faced with a child who is upset in front of you. It's not a situation that you are easily, you know, kind of know what to do a lot of times. And you just often will go to what feels comfortable or what feels like the right thing to do in this situation. And what feels right could really vary a lot based on your own personal experience. So we try to kind of approach with that idea that whatever you're doing your best to start with. And, you know, what we're talking about doing is just, you know, using your attention, using your energy to try to promote the behaviors you want to see more of. Now, of course, in certain situations and certain settings, for example, in the program of work that's being done both in Chicago in the United States and in Calgary in Canada, working with parents who have mistreated their children at some point and who are in a different service sector because of maltreatment. We are approaching these ideas in a much more cautious way. When is the parent really ready to adjust their behaviors? When are they ready to engage in something like exposure with their child, given that they've had frustration tolerance issues in the past? So certainly depending on the experience of the parents, you sometimes need to scaffold or adjust your strategy approach and take your time to make sure that the parent can handle doing something different and handle it well. But I think generally speaking, that personalization has been something that has been pretty easy to accomplish within the materials.
Jill, thank you very much for sharing your time and your knowledge with us. It is a wonderful program that you have developed and implemented. And I think we all are very excited for your Spanish version to come out, and that way we could also use it here in Mexico with your training. I want to thank also Dr. Elias Góngora from Universidad Autónoma de Yucatán for collaborating with us in this series. And all the participants, thank you very much for being here and for your time. And we look forward to see you all in the next webinar. Thank you very much, Jill.
Thank you. Thanks for having me.